So, by way of introduction, I'm going to tell you about the sessions for the Scholarly Concentrations Group. And first, what is that? So, for many years, I would go to the AAMC and kind of wander around, not really having a home. I'd say, I could learn something about the LCME. I could learn something about the NISP, but it wasn't what I did. And it seemed like there were a number of other people in that situation who were involved in medical student scholarship, who didn't have anybody really to talk to about what they did and to learn from. And so about 3 years ago, an informal group kind of coalesced, and it's called the Scholarly Concentrations Group. Scholarly programs, scholarly concentrations. And there have been different kinds of presentations during the 3 years. The first year was just sitting together. I didn't even know what was meant by scholarly concentrations. I didn't know who it really applied to, but I decided to go, and fortunately I did, because it's not well advertised. The next year we had a formal discussion group with presentations, and that was useful. And this year, we tried to get something, to see if we could have a plenary or something more formal, and honestly didn't hear back from the AAMC at all, which may have been their answer, or just may not have been. It may have just gotten lost. But so the group put together some informal over-breakfast sessions. So it's a little bit of a hodgepodge. And they were devoted towards discussing programs that different schools have. And there are probably about 25 schools represented in the group. Discussing mentoring and evaluation of programs. So I did the session, I facilitated the session on mentor, recruitment, training, and evaluation. And of course, part of the reason was selfish in that this is something that I think is probably the single most important, mentoring, the most important part of a successful independent study program, in this case, research and scholarly project oriented. So I was glad to organize it and have a bit of control in how the session went. So the first thing, they were 1-hour sessions, as I said, over breakfast. And the first thing we did was discuss about recruiting mentors, since you have to have mentors in order to be able to have people to supervise your students and to direct them. And it was agreed upon that at most schools, recruiting sufficient mentors is a problem. Certainly, I could have said a challenge. It doesn't happen easily. Everybody agreed, and this has certainly been our experience. I think in anything you want to do, it's not just recruiting mentors. Blanket emails don't work. It is rather an arduous process to recruit mentors, but frankly, I think it's worth the time. It's one of these, I think, quality in, quality out. And therefore, I'm sorry, it should be low-tech approaches. That's, the speller didn't get it because it's a word. So low-tech approaches, meaning direct contact, calling people, seeing people face-to-face. I find that this works in explaining to them what the program is about. I have recruited my mother's surgeon when she had her aortic valve replaced. I have recruited people in the fairway. Oh, hi, nice to see you. By the way, so nobody runs yet when they see me, but honestly, I say this, it's just, you've got to talk to people. You've got to connect with them. Obviously, some schools, one in particular, University of South Dakota, talked about having multiple campuses in their state, which are very far apart, and they devised a video. This is a regular run-of-the-mill video. It's similar to the video that was just done, the very nice video for admissions. It's nothing like Rainier is doing with voiceover, but what it does, they sent the link, it has mentors talking about why they like working with students, and it has mentees discussing the benefits. And so this is something that might be useful. It's still not a person-to-person approach. And people felt, though, and I think this gets back to the low tech, if you know people, Brown was saying they have tracks, a number of scholarly concentrations. They don't have a problem in that way. And I shared that I think when program directors take control of mentor recruitment, it doesn't ensure quality unless you know who you're inviting. But it can get people to at least give the experience a chance. Retention is another problem. After you have your mentors, you have to keep them in the program, and we all know the thing we're dealing with is everybody's extraordinarily busy. So some kind of indirect, I think for any situation, some kind of direct or indirect reward has to be there for the individual, for the mentor. So the University of South Florida has education value units, and this is their way of quantifying mentor involvement, something that, of course, can be used for promotion, therefore. Some schools give a course number for the scholarly programs. So again, if they have T dollars or if they have some kind of recognition, credit, as it were, given for teaching, that's how that can be decided. And, of course, there are the less direct rewards, establishing a relationship with a student, having the ability to influence a student's career, which is very real, perhaps less frequent with someone who's doing a scholarly project after their first year, but certainly during the scholarly year, and we have upwards of 30% of the third-year class that does some kind of scholarly year usually after their third year. Some schools have mentorship awards, and of course criteria is an issue. And it was discussed, perhaps if you're going to have an award, don't just discuss the one person who wins, but discuss the finalists as well. Kind of like you can get the Academy Award, but it's really nice to be nominated as well. And so this will recognize and reward greater numbers of people. And then there are things like a pin, a little token, a pin or a certificate. I think something that IME does for faculty members, mentors, an specific email thank you, a framed photo of the mentor and the student. For us, that would be triple-digit photos, or some kind of end-of-year event, which, of course, may or may not be well attended. Another thing that was discussed in ensuring a good relationship and a good experience by both the mentor and the mentee is to align expectations. And some schools have a mentor-mentee contract, which helps to outline at the beginning of the experience what each wants, what each expects. So you're not taken by surprise. I think it's very easy for students to be disappointed they're not getting something from a mentor, and I've heard this because they don't communicate it, and it's certainly very easy for a mentor to be disappointed as well. The student may think he or she is doing a great job, but there may be something that doesn't fit with the expectations, either in terms of style or substance by the mentee, and this can be an important learning experience for both, in fact. And certainly it can identify problems early before they get out of hand. And so we come down to metrics now, evaluation metrics. Some schools have an evaluation form. I called it here an end of experience form. And we have that, and the University of Chicago discussed theirs as well. And I have a copy of it. It's similar to ours. schools vary. Not too many schools did this. I find it enormously helpful. One of the things I use it for, their anonymous student satisfaction with the program and with the mentor. And I make sure the students know that this information about their mentors, even though they're anonymous, in most cases there's an N of 1. So I know who's working with the student, but I tell them that I need this so that I can best advise students in the future and know, a lot of times I know good mentors, supportive mentors, and I know who is less supportive, but there may be new people. And it's just helpful also to get the student's perspective, because as I tell them, my relationship with a colleague is very different than the kind of relationship they're going to have. And somebody can be a lovely person and really have good intentions, but somehow, not either give mentoring the priority or not really know how to do it, and it doesn't work out well. So sometimes these forums could be used to give feedback to the mentor, somebody who wants to be a good mentor, and to identify, as I said, successful or unsuccessful mentors. And again, in some cases, the data can be useful for promotion. Obviously, those are data that are not collected anonymously. So for medical students, which outcomes should be evaluated? And everybody's asking the same question, and this group is asking it, the Howard Hughes Foundation Medical Institute is asking it, the Doris Duke. Everybody who supports medical student scholarship is asking, how do we know if our programs are successful? The usual metrics that at least are used for even residents, fellows, and faculty certainly, are not applicable today to medical students, because we can't ask, really, are they publishing? They're doing their projects kind of, unless it's a scholarly year, and even then it's only 1 year, they don't have the time commitment that faculty have. The grants they can apply for are very limited, so satisfaction is not usually a satisfactory outcome, but I think there was general agreement in people who are responsible for scholarly programs for students that this really is very important. I think you have to think out what your goals are. And if one of my goals is to give students a stimulating and experience that really they find very satisfying and that encourages them to think more about combining medicine, clinical medicine with research, then you want them to be happy, you want them to enjoy it, and you kind of want them to leave the program, whichever it is, wanting more. So I think satisfaction is important as time goes on, but it's a lot of time. Then we can look towards how many people in programs begin an academic career. All the major foundations are looking at that. The Doris Duke Foundation is looking at that to see, their board of trustees wants to know, is the program, which is relatively new, it's just about 10 years old, the Doris Duke Clinical Research Fellowship Program. They want to encourage people to become physician scientists. Is it really doing that? Or, I don't believe this, but is it a one year of just kicking back and kind of relaxing between third and fourth year? And of course, then we can look at grant and publication records. But our first 2 graduates of the Doris Duke program, 2002-03, just finished their training. So that's how long it takes. An N of 2 doesn't tell you very much whether you like what the data say or you don't.
What do you happen to those 2?
One of them is doing an academic career. One of them is in consulting. So I think you could medical issues, but with McKinsey type economic. I mean, that's Ben Cornicer, who was here. You know Ben. Do you remember him as a student? And he did yes. He did his medical training at MGH, and he did a Doris Duke. with Roseanne Leipzig. He was one of our first. The first year we had the Doris Duke, and we had 3 slots that year, and we couldn't fill them all because we only had 2 applicants because nobody knew what the Doris Duke program was. So we took the 2 who applied and 3 outside students. It's health policy, but not exactly. But anyway, that's another. And I just wanted to tell you about, along the lines of mentoring, and one of the other reasons I was glad to do this program, the Scholarly Concentration Group program, the discussion group, was because Mount Sinai is participating through the CTSA in an NIH-sponsored mentoring intervention. It's a trial. It's a randomized, controlled educational trial of whether a mentoring initiative is effective at improving students' perception of their mentor's abilities and of the mentor's own perception of his or her mentoring ability. And it consists of 8 hours, 4 2-hour sessions, and the issues that are being discussed and focused on are maintaining communication, establishing expectations, addressing understanding between the mentor and the mentee, addressing diversity issues, which are important in communication and good mentoring, fostering independence of those trainees who are ready to progress, and promoting professional development. The program was developed by the University of Wisconsin faculty. There are 14 academic health centers, all of whom have CTSA programs. Janice Gabrielov and I went to Madison, Wisconsin in August to be trained as facilitators. And basically what it is giving a questionnaire to the mentor and the mentee at baseline, and then having the intervention, and then the mentor will fill out the same questionnaire about his or her skills. The students should not know whether their mentor is participating, and then the entire group, those whose mentors are participating and are not, will complete the questionnaire about mentoring skills afterwards. So we're in the middle now of carrying out those sessions. And I just want to conclude briefly. Everybody was supposed to take notes at these sessions. I think that's one of the problems with an informal session. It didn't really happen at all of them. But one of the sessions was on program evaluation. This was led by Bonnie Miller, who's from Vanderbilt, and she just sent me these yesterday. They were going to put things together at Brown and send them to the entire group, but it didn't happen. And so in terms of how to assess students who participate in scholarly programs, most of the schools who have scholarly programs, at most of the schools, the programs are elective. A few have required programs, but that's much less common. And for the elective programs, assessment is generally given via feedback from the mentors, and in most cases, no grades. And this is what Lisa and I developed for Inspire. We had an evaluation form that went to the mentors that they filled out, and then the mentors just sat down with their students and discussed them. And we do this as well for the Doris Duke program. For the few required programs, feedback is certainly a part of it, but usually in those cases there's a grade, and mostly it's pass-fail. Virtually all programs require a final product, which in most cases is a poster, but can be a talk. And there was general agreement that it's hard to have a single set of criteria to judge the project since they vary considerably. And so one thing we do is try to have different people on the evaluation committee who have experience in different kinds of research. Somebody who might have more experience in basic research, someone in clinical, somebody in community-based, so that they can better evaluate what the student is doing. And again, in terms of evaluating the program, mentor and student satisfaction with the program, something we do as well. And here too, longer-term outcomes. things we look for. They may be not thinking out of the box, but thinking out of the box is hard to do for large numbers. Follow-up surveys are necessary to get these data. I will tell you that the Doris Duke Foundation requires an annual survey of alumni. They send out probably 2 or 3 blast emails, probably get something like a 30% response rate, and then turn it over to the program directors. We've done very well. We actually lead all 12 schools. I will say, because by sending individual email, and I think, I find if you let students know why something's important, they're all busy. I mean, they're all residents or fellows or training, but if you let them know that, and it's true, that the program depends upon, continuation of the program depends upon the foundations getting these data, they do respond. Columbia had the worst record. I'm just throwing that in. Yeah, it is. But, we haven't lost anybody yet. The foundation, all the foundations, the Hughes and the Duke, they try, they look, they will even Google. I've Googled, I've tracked people down. I suppose what's going to happen as the programs get older is that you're going to have somebody who's not training anymore, is just out in the world, and that is going to be difficult.
How far out do you go now?
Well, it's the program, 2002 it started, 2002-03.
Some of them...
I said before you came in, some of them finished, or our first 2. The first 2 participants did, but I think probably the last time we did it, they were just finishing their training. I think they finished last July. Well, now we have 8. That year, we had only 2 Sinai students, and then we had 3 for a few years, but now we have 8. And we're 8 total. We must take 2 outside students from schools that don't have Doris Duke programs. It's the Foundation's attempt to make the opportunity to participate available to everybody, although we get among the greatest number of applications. I think UCSF, Harvard, Columbia, Mount Sinai, we get over 100 applications for 2 spots. So, any questions? Okay, thank you, everybody.
On how to actually measure lifelong learning. And it's particularly relevant because we're in the midst of LCME self-study, and one of our EDs, one of the standards, asks us how we actually teach and assess lifelong learning. This was a presentation from Virginia Commonwealth University in conjunction with Thomas Jefferson, because they had developed the original survey. And I went back to the original literature, and so the bulk of what I'm presenting actually is the original literature leading up to the modification of this tool for medical students. So just to start, so we're all on the same page, and these are not my definitions, but if you look back through the education literature over the last 40 years, there are many terms for lifelong learning, which include self-directed learning, self-educative approach, self-initiative learning, active learning, independent learning, contextual learning. And it's deemed a critical competency by the AAMC Medical Schools Objective Projects, by several of the objective projects, and the last one said medical students should develop skills and motivation to engage in lifelong learning to stay abreast of relevant scientific advances. In terms of the LCME Standard 5A reads, it is expected that the methods of instruction and assessment used in courses and clerkship rotations will provide medical students with opportunities to develop lifelong learning skills, including self-assessment on learning needs, the independent identification, analysis, and synthesis of relevant information. Medical students should receive explicit experiences in using these skills, and they should be assessed and receive feedback on their performance. So we were asked the question below, and we had to answer. Describe where and how in the curriculum there is assessment of students' progress in developing skills needed for lifelong learning, and how do their abilities to demonstrate these skills contribute to their overall assessment. So in looking at all of our courses and clerkships and how we assess this tool was actually quite relevant, and I was actually thinking of it for Karen in terms of pre-Doris Duke and after Doris Duke to see if there's a shift in lifelong learning and self-directed learning related to the program. So the history is that there were definitions and sort of a statement about it, and the features of lifelong learning are thought to include personal motivation, recognition of needs that prompts an active search for knowledge, and information-seeking skills. So there's sort of three domains that are critical for lifelong learning. Turns out that there was a self-directed learning readiness scale that was created in 1977 and used by universities. And middle states actually hold universities accountable for assessing lifelong learning in all of their students. So this scale was modified in 1991, the literature goes way back, by Friedman, and he shortened it and actually looked at medical students. And what he found with this scale was that there was no difference between first-year students and fourth-year students. So he concluded that our curriculum couldn't improve medical students' lifelong learning. That laid dormant until Jefferson decided to modify this, and they presented it in 2003. And it's Tom Nassa, John Velocki, Joseph Ganello, and a couple of the others. So basically, they got 12 medical educators together, and they asked them to define lifelong learning. And their definition was, and it's basically four aspects. There's a behavioral aspect, which they said is self-initiated activities, a capability, which is information-seeking skills, that are activated in individuals with sustained motivation. They call that predisposition. And the cognitive aspect is the ability to recognize your learning needs. So those faculty then came up with 40 statements that they thought best defined lifelong learning within these four domains. They then revised them. They had an independent review by another 15 faculty, and they came up with 37 items. So their original survey was a 37-item tool. They sent it to about 400 physicians in practice and got like a 40-some% response rate. So 160 physicians initially responded and completed the survey. They then did item analysis of the 37 items and came up with 19 items that was their final Jefferson scale of lifelong learning. So it originated in 2003, and then they modified it in 2006 to make it a 14-item survey. The survey then is a Likert scale from 1 to 4, and there are 14 items, so the maximum score is 56 if you total up all of the items. And it's from I strongly disagree to a strongly agree with the following statement. They said they called it, there were three domains that encompass these 14 items: learning beliefs and motivation, attention to learning opportunities, and technical skills in seeking information. And each of these statements fell under one of those three domains. So this is their 14-item scale. Searching for the answer to a question is, in and by itself, rewarding. Lifelong learning is a professional responsibility of all physicians. I enjoy reading articles in which issues of my professional interest are discussed. I routinely attend annual meetings of professional medical organizations. I read professional journals at least once every week. I routinely search computer bases to find out about new developments in my specialty. I believe I would fall behind if I stopped learning about new developments. One of the most important goals of medical school is to develop students' lifelong learning skills. Rapid changes in medical science require constant updating of knowledge and the development of new professional skills. I always make time for self-directed learning, even when I have a busy practice schedule and other professional and family obligations. I recognize my need to constantly acquire new knowledge. I routinely attend CME programs to improve patient care. I take every opportunity to gain new knowledge and skills that are important. And lastly, my preferred approach in finding an answer to a question is to search the appropriate computer database. So they used that survey and polled over 5,000 of their graduates, and they have had for the last 25 years, and I know because I was a graduate, they have had an incredible database and ways to find absolutely everyone. Despite changes in name, they will hunt you down. They also ask and get a lot of money from their graduates. And so they polled basically 25 years worth of graduates, and they got a 58% response rate, which is really remarkable considering that it's 25 years worth and they had to follow those people. Their scores correlated interestingly with the quartile in the class. It was a self-directed learning piece and their performance in medical school that correlated. Their scores correlated with their professional accomplishments, so the more professional accomplishments you have, the higher your self-directed learning scores. In addition, they correlated with career satisfaction and with a self-rating of commitment to lifelong learning. So aside from those 14 items, they asked them to say, are you committed to lifelong learning? How much do you agree or disagree? And there were no demographic differences in the scores by gender or ethnicity, but MD PhDs tended to have a higher score than MDs. So the group from Virginia Commonwealth took this 14-item survey, and you can see that it clearly had a lot that was directed at physicians in practice. And they decided to modify it. So they reviewed the 14 items. There were 8 authors that reviewed the 14 items, came up with 8 items, revised them, and then sent them to 30 faculty and 30 medical students for validation. And they were looking at face and content validity, internal and construct validity. And they then modified with the suggestions and came up with 8 items that they felt were valid. They then handed it out to all 4 years of medical students, 732, and got an 89% response rate. They also did retest reliability with 40 students and showed a significant correlation between their retest answers and their original test answers. And this is their modified scale. Rapid changes in medical science require constant updating of knowledge and development of new professional skills. One of the important goals of medical school is to develop students' lifelong learning skills. I recognize my need to constantly acquire new professional knowledge. I believe I would fall behind if I stopped learning. Lifelong learning is a professional responsibility of all physicians. I enjoy reading articles in which issues of medicine are discussed. I routinely search computer databases to find out about new developments. I read medical literature in journals, websites, or textbooks at least once a week. I always make time for learning on my own, even when I have a busy class schedule. My preferred approach in finding an answer is to search the appropriate database. I take every opportunity to gain new knowledge and skills that are important to medicine. I routinely attend optional sessions such as grand rounds or clinics. I routinely attend meetings of student study groups, and searching for the answer to a question is rewarding. So what they found is that they were concerned that because of the social desirability of students saying that they were lifelong learners, that in fact they would falsely rate these items. But they found significant variability in an individual student's responses to those 8 items. So some of their responses were rated at a 2.3 and some were at a 3.9, which would lead you to believe that they truthfully answered those items because there's a lot of variability. And what they found, which is encouraging, is that as students progress through medical school and then into practice, their lifelong learning skills improved. And that was manifest by the scores increasing, and they were statistically significantly different. So after first year, the scores were about 42.8. At the beginning of fourth year, the medical student scores were 44, and as physicians, they were 46. So the total mean scores for physicians were 46, and for students were 43.52. So they concluded in saying that this was a reliable and a valid way of measuring lifelong learning skills in medical students.
Are we in one of these things where it's statistically significant, but who cares for that small a change? And it's a change in many of them expressed attitudes, and it's not clear whether the changes are in attitudes or in actual behaviors.
Right. Well, right. They didn't profess that they were actual behaviors. They clearly are, self-assessment, and so they are attitudes. I think that the fact that those attitudes changed is meaningful. Now, whether those translate into behaviors or not, I don't know. When you look at some of those items, it's clear that at the end of first year medical students might not be reading up on journals and doing those kinds of things, so you would expect that some of those items...
They have textbooks in there, so you sort of compensated for the article stuff by using textbooks. I mean, one of the reasons I'm interested in this is whether, as a faculty member, I'm doing students a disservice when they come and ask a question, and I answer it rather than say, why don't you go do some research on it and ask me again tomorrow. I don't know whether that would be, I guess the closer it comes to the exam, the less well that would be accepted by students.
Right.
But I'm just wondering whether, there's something we should be doing or not doing to push students towards finding the answers to what in most cases, not all, but in most cases are fairly simple factual questions. The textbook said this, and the syllabus that so-and-so gave said that. Which one is right?
Well, I think we wrestle...
It doesn't take a hell of a lot of work to find out where that difference comes from.
I think it depends upon whether it is a very simple answer or it's a concept. And, we wrestle with this all the time when we teach students on awards and residence, and that's why there is a lot of faculty development around trying to get the learner to actually understand what it is they need and to look that up. And so instead of just giving the answers, you have to frame it and say, well, what do you think is important? Why do you think that? So I think, trying to get at what their misunderstanding is. If it's something as basic as is the text true versus is what you wrote true, I think it's easy enough to answer that. That's not a concept, or that's not someone who is being lazy. I think, if students understand the concept, which is what you want them to get at, and they're able to solve it, then that's what you want. If they're being lazy and they just don't want to solve the problem, if they understand the concept, obviously you should then say, well, you should solve this, and then tell me and show me your work and why you can't, if you didn't get the right answer. But I think we do actually try to motivate our students to lifelong learning. I think most of the small groups that we have in the first 2 years do that. At least that's what we put down for the ED5A.
Every day for the applicants that we do.
Right. Well, maybe we should use this scale and see.
So, are you planning to use this? Try to assess. Can I just say something about the scale? That one thing that it's missing, I think that if we were to use it, I don't even know if we could modify it because this really has validity. But is actually the piece about community, a community of learners. And they really don't assess whether or not you collaborate with other students, whether that is an important piece of your learning. I think that actually is really critical. And they don't really sort of tease that out, whether or not students like to collaborate. Because I think that as physicians, certainly, that's one of the ways we sort of engage in lifelong learning. It's sort of like one of the practices is actually participating in conversations with other faculty, getting sort of various opinions. And they don't really tease that out. I'm just curious.
They don't, but I think it actually ends up being disconnected in the end because many physicians in practice who aren't in academic medicine, and the bulk of physicians are not, are isolated in their practice and not doing that kind of collaborative discussion except if they're doing a consultation. And so, I think it facilitates learning, but I don't know that you direct your own learning in that. And it's very easy in a small group unless the facilitator forces you to just sit back and to hear what other people say. We try to assess whether the students come prepared because in our minds, and then that they contribute, that's lifelong learning. But it is very easy in a large, small group to just sit there and to take in what everyone else does, and that doesn't mean you're a lifelong learner.
Right. No, I agree. And so I don't necessarily mean as like the actual activities, but actually how students, they don't really sort of tease out whether or not students. Yeah,
yes.
Skill-based learning, I think, is a really essential way, even when you're out in practice and sort of yourself. Many of these physicians actually do have collaborations in the hospital, or they're working with other members of the team. I mean, I'm just curious. I just feel like that's a piece. There was an negative connotation in there, and that it said the way that I find answers is to go to literature, which means that's the only way. And that's what a consultant you can't figure out. You go to the literature, but you can't really find the answer. Is to me, they're saying that's not. You don't care about lifelong learning. Yeah, I feel like that's a very simplistic way of looking at lifelong learning.
Because that's the three elements are viewed, at least the way I heard them, as equivalent. For me, far more important is the contextual need to know. Either to do your job as a physician, or do your job as a researcher, or do your job as a teacher. And I don't see how students, frankly, they're learning what to know, rather than experiencing a need to know because their learning base is deficient. I'm not making myself clear. There's a lapse in time that lifelong learning still, you bet.
Yes.
I think this is a instrument of the review that you guys are going through, and you got to do it, but it has far greater meaning for a residency program or a program for students.
I know Eric is right too, but I think the reason it goes up is because there are about 3 questions that a first-year student isn't going to. It was more about functional piece.
Right.
How do I look it up rather than my desire to look it up?
Right.
I think that
the desire to
assessment to
It's keeping up to be the best you can do.
Right. But you see, but it's a critical goal for undergraduate universities. It's mandated. So in theory, students should be learning that in undergraduate. And if we claim, in fact, that we're not sure our students know or need to be lifelong learners in the first 2 years, then why did they really need to be at the undergraduate level? So I think there are. I do think that we try in the first 2 years to pose problems that the students need to sort out on their own without giving them the answers. Certainly in the 3rd year, when they're actively involved with patients, that does occur. So I think that there is.
I think all of that makes sense. Sort of having to come to the small group, having prepared. But I think it's more the other things that you guys have put in. It's the pass-fail. So we are saying we don't want. Hopefully, what we're saying is don't get 5 points below the mean so that you pass, but actually use this time to figure out how you learn best and learn for the future patient. I think it's the anatomy team group where you have to be collaborative and work together. I think it's the exams open for 3 days where you have to be in charge of your education and have adult learning and say, I'm going to take it on Thursday, I'm going to take it on Sunday. I think all of those, I think those initiatives are treating them like adult learners, not infantilizing them, and hopefully empowering them to love learning. I sound idealistic and crazy, but I think those things are the things that we put into place that are hopefully making them have ownership over their learning.
I wonder too if I don't know how much it makes sense to do a self-assessment. I'm wondering if something like this could be more so that you have
your faculty are rating this.
Your faculty advisor even. I don't know. That's a lot for a faculty advisor, but someone in mentors actually assessing that at the end of courtship or at the end of your years in medical school. This is why it actually makes sense to actually have faculty advisors, somebody who could actually see the progression from the first year to the 3rd and 4th year. I'm just wondering if the self-assessment is not. I don't know.
Well, I don't know that it gives us all the information, but what I think it does is set the right framework for students to understand what we believe lifelong learning skills are, and to look at themselves. Any self-assessment, there's not a lot of validity to the information. However, if you do think you're getting better at that, or at least you recognize over and over again and are assessing yourself on these skills, I think they become embedded, and there is an understanding that these are the things that are important for physicians. So, if nothing else, we're drilling into their brains. These are the aspects of lifelong learning that we expect you to be able to do. Right.
The attitude is hard for someone else to get, because you could argue that the person is extremely motivated. They've never discussed that with their advisor.
Right. Like I would like to, or right, how can you assess that?
It's hard to assess, period. At least there's something out there. So there's something for alchemy, is that it?
I think the best example of inculcating lifelong learning is in the room. There are a number of people that are role models that demonstrate visibly and credibly the value of lifelong commitment. I think that's part of our best show.
Good judgment comes from bad experiences, which comes from bad judgment. That's lifelong learning.
No, you're absolutely right. We're all here learning today.
Well, it's very easy to teach a resident how to operate. It's not so easy to teach them when not to operate. And that's the difference. And we have a whole different, at least I personally have a whole different view of lifelong learning than I think some of the so-called educators do. Because we're constantly looking at our own experiences and making changes related to them. We're trying to figure out what's the standard of care and how do you push the envelope a little bit. And a lot of the stuff that we do has not been validated by randomized controlled trials. I mean, look at laparoscopic surgery. This was done by a jazz musician, basically. He started it, and the public demanded it. And you had to either get on board.
Good reason.
Get on board, or you went down the wayside.
I think it's a really good point, though. The reflective piece isn't necessarily in there either. It's sort of the way you reflect on your own practice.
Okay.
I think that's actually really critical of the lifelong learning. How do you reflect back on your own mistakes, and how do you take sort of corrective action?
Although I think it might be hard for somebody other than to say I reflect back and for you to dissect that out and put that as an item.
Although I wonder if some of this stuff was in there. They kept cutting it and cutting and cutting it. So I wonder if some of that stuff was in the big first one.
But it didn't correlate.
Even at 17 or 14, it seems that it's particularly the students. It's almost like some of the questions are asked about
A little bit.
previous answers. But go ahead.
Well, we've got 5 minutes, and the good thing is my presentation is very short, and I decided to do something different this year. And instead of talk about a session, there are these really big plenary sessions at AAMC, and they have big speakers, and they draw. Oh my God, that was the biggest. Well, Malcolm Gladwell was there. It was the biggest group I've ever seen at a AAMC conference. There was a set of stairs going up to the exit, and every spot on the steps was full. It was standing room only, and so they had multiple people presenting, and I don't know the titles of everyone. But Daryl Kerr spoke, and the two I was just going to summarize very briefly was Daryl Kerr spoke, and then Malcolm Gladwell spoke after him, and both were absolutely riveting. So Daryl Kerr is one of these, he's the president and CEO of the AAMC, and he's one of these people that is incredibly inspiring when he speaks. And it's funny because, I went back and I took all these, I was probably driving people crazy on both sides of me, so I'm like, this is what I'm going to talk about. So I was texting myself the whole time of what he was saying, and then of course they printed the entire speech on the website.